Tonight, like I said, we'll be doing a ergonomics town hall forum. We'll be talking about illnesses to the elbow, and it's part of the anatomy of an injury series that we've been going over. If you've been to our past mission controls, we appreciate everyone attending tonight, and we're excited to hear from Dr. Greg Pitt. For today's rules of engagement, biggest thing is, like I said, we'll be mostly hearing from Dr. Greg Pitt, and then we have a group of panelists, a lot of expert ergonauts, occupational health experts, and they'll be asking a lot of questions. But if you are just if you're an attendee, feel free to put your questions in the chat, and we'll get those answered as well. Again, thanks to everyone for being here. And we just want everyone to know that we will be recording this for later use. And just please, everybody, be respectful, and we'll get to everyone's questions as soon as we can. Again, we'll be hearing from Dr. Greg Pitts. Any questions we'll go over at the end, or if the time is right, I'll be asking him from the chat. Just a little bit about Dr. Greg Pitts. He's one of the top hand therapists in the world, and he's been giving us a few mission controls talking about the limbs and the body, upper extremities, and now we're going into the elbow. He's got several clinics that he works and he consults for various other clinics throughout the country. So, like I said, he's one of the top hand therapists in the country. So again, Dr. Greg Pitts, we appreciate having you here today, and we'll give over the screen over to you so you can give your presentation. Appreciate you.
Thank you very much. I'm excited about being here tonight, and I will attack initially the we'll talk initially about the lateral elbow. I can pull it up. All right, so well, you don't see it now. Sorry, a little technical difficulty here. Trying to get it pulled up.
No
you see my screen?
Yes, sir. We got you.
All right, now let's see if we can pull it up here. Now here we go. Now you got the anatomy up, right?
Yes, sir.
All right. So the first topic we're going to talk about tonight is lateral epicondylitis, and it's a very, very prevalent problem in industry today. It's very, very prevalent in car industry, particularly, and it's there for several reasons. First, I'm going to go over just the basic reasons why we have lateral elbow pain. So lateral elbow pain is pain that occurs right here, and for those that have had it, can be very haunting. And the reason why it's a particular problem for people in industry is because there's 5 different reasons why you can have lateral elbow pain. 5 reasons why. And so what happens is when you go to the doctor, particularly a general practitioner, they have a hard time doing all the different diagnostics that is required to look at and determine what is causing the problem, the pathology. And so we'll talk about the pathology, and we're going to talk about the risk factors and the cost. But pathology first, lateral elbow, is very interesting that you can have your first pathology can actually be from your C-spine. C6 can cause pain down your arm into your lateral elbow, which is often overlooked. That's number 1. Number 2, you can have tendonitis. Lateral epicondylitis, tendonitis occurs right here, right focal to the epicondyle. The culprit in that problem is primarily the extensor carpi radialis brevis. That's the only muscle that is the pure wrist extender of the wrist. So this muscle gets in trouble when you have to reach out for long reach envelopes, and you have to grab something with your hand in a pronated position, your palm down, and you pick stuff up with a lot of weight, and it creates a lot of stress on this muscle. And this muscle works through an eccentric phase and a concentric phase to hold the wrist steady, and it can get in really big trouble. And so that's number 2 on the list. Number 3 on the list, I'll take some muscles away now. I'll mark it here, is right here, and it's the radial tunnel. So there's a nerve that comes out of our neck and goes in behind our arm, and comes out through our tricep and goes into our arm here. It's called a radial nerve. This nerve can be trapped by three muscles: the supinator, the extensor carpus brevis, and the extensor communis muscle for the digits. So this muscle is trapped at what we call the arcata feroce, and it's a very, very common problem. And so now we have a C-spine problem, possibly. We have a tendon problem, possibly. We have radial nerve compression, possibly. And then now we'll strip the muscle away, and we will go down to the bone. We look at our bone. We'll add connective tissue here. And there are three major ligaments in the elbow on the lateral epicondyle. You have the radial collateral ligament here, the lateral ulnar collateral ligament here, and the annular ligament here. Now, for purposes of this anatomy, it looks very distinct. But if you was to open up a cadaver up, you would not see it this way. It'd be all blended together. It'd be one big ligament. But these ligaments do very special things. The radial collateral ligament primarily protects us in extension, as well as the lateral ulnar collateral ligament in extension. So when we extend our elbow, it stabilizes the elbow. Quite a unique, cool design, because as your elbow extends, both the bicep and the tricep are both limited in how much they can stabilize your elbow. So you want ligaments to stabilize the elbow. And then your annular ligament actually controls the radial head as it rotates through pronation to supination with load. So if this ligament fails, we've got a big problem with stability of the elbow. So all three of these ligaments, the radial collateral, the lateral, the ulnar collateral ligament, and the annular, all create stability of the elbow with the elbow extended. Very, very important, particularly as we talk about occupational hazards and risk factors. The last but not least is the radial head itself. And the radial head itself can develop arthritis. So as we talk about the aging workforce, particularly in males more than females, there's about a 15% more prevalence in males and females of radial head irritation or arthritis. This can become a big deal. And so as you load or push off, or you weight bear, or you crawl on your arms, or you swing a sledgehammer, or you run a jackhammer, or you climb utility poles, and you bear weight and you put force through your arm, it can cause a shear mechanism between the capitellum and the radial head. And if you have any arthritis that's occurring, usually in the 5th decade of life, usually in males, then you got a big problem, because this can be really debilitating, causing all types of problems with functional range of motion and the ability to do work, particularly weight bearing work. So to recap, we got C-spine, C6, we've got tendon, we've got nerve, we've got ligament, and we've got actual joint. So there's 5 reasons why people can have lateral elbow pain, and they all have different occupational risk factors. So let's back up now and go through the risk factors briefly as we talk. I'm going to add muscle to this structure. I'm going to pull it out so we can actually see the neck a little bit. So, you know, the C-spine gets in trouble when you have very poor posture. So when you have very poor visual line of sight, and your neck pulls forward into a forward neck posture, puts a lot of stress on the muscles and the joints in your neck. And so it creates compression, and can compress the vertebrae and the disc in the neck and cause a bulging disc, which can actually create stress on the nerve root. And then that can cause radiating pain down the arm. So we have very poor visual controls, very poor lighting, glare, whatever that can cause it. Also, if you turn your neck a lot in work, like as a forklift driver, if you turn your neck back and forth a lot, it can actually cause a lot of stress and shear on the discs themselves. Not to mention the fact that we lose height in our discs as we age. So posture, rotation, poor visual controls, and poor visual ability to see. Remember, the human is 80% motor control is through visual alignment and visual feedback to our muscles. So if we can't see, we're going to get to where we can see. So this is really, believe it or not, a big population with this problem is actually surgeons, believe it or not. and also people that are working the chemistry fields where they have to have a lot of fine motor dexterity and be able to see through lenses or actually see clearly what's going on. Now we'll move on to the next problem. We talked about tendons. I'm going to zoom into the tendons here. These tendons get sick, and they get sick along the insertion site of the muscle. And so it's called lateral epicondylitis, lateral on the lateral side. Epicondyle is just naming the two sides of the elbow, the lateral medial elbow, if you will. And then itis is inflammation. So these tendons get sick, and they get sick right along the origin site. The origin of the tendons get sick all around the epicondyle. And when they get sick, they put out pain mediators, such as histamines, mast cells, P substance, all these things that make it hurt. And when it hurts, it actually creates a pain reflex. It changes your kinematics. You don't want to straighten your elbow out. You also can have some irritation, actually, believe it or not, around the tricep muscle a little bit. And as a result, we change our kinematics. Well, when we change our kinematics, it's a problem. So when you straighten the elbow out because the muscle crosses the elbow joint, you put more tension on the tendon, which creates a pain reflex. And when that happens, you change your kinematics. And when you change your kinematics, the trunk will shorten. The scapula will go into a protracted position. It will destabilize. So as you reach your arm up to do an activity and you try to extend your elbow, it's going to create a chain of events that occur. And so it hurts. You got pain, which creates trunk shortening. It creates the scapula destabilized because you're still trying to do the activity. You have trunk rotation. And so you're trying to reach an object out here in space, you're trying to reach an object to do an activity, and it creates problems. So when your scapula becomes destabilized, it makes the muscles in the elbow work harder. So it's a vicious circle of pain, destabilization, and then more stress on the elbow. It's a vicious cycle. People often describe this problem as like having a crane, and you're working with a crane, and all of a sudden that crane pulls up on the one track. That's what happens when your scapula destabilizes. It goes into protraction, and it creates a big problem with destabilization. And as a result, you have more stress on your lateral elbow, which creates a bigger problem. And this is usually caused from the tendon injury itself, but also from large reach envelopes. So anything that exceeds 14 inches of a reach envelope is a very big problem for you. You're setting yourself up for scapular destabilization, trunk shortening, and lateral elbow problems. Then with you add force to it, so you got reach, then you got force to it, then you got repetition, or so you got load and repetition. It becomes a big deal. So reach, load, repetition puts a lot of stress on this muscle. Last but not least to talk about is the fact that this muscle group is in what we call a watershed area. So a watershed area is a place where there's very poor blood flow. And so as a result, if you got poor blood flow, it means it's going to heal very slowly and susceptible to injury. So it's like the perfect storm in the upper extremity for problems, because it has multiple reasons why it gets sick, i.e. C-spine, tendon, radial nerve, ligament, and radial head or joint itself. On top of the fact that it gets sick because work areas are designed poorly, which makes our skeleton destabilize, creates destabilization with large reach envelopes. So when you get the perfect storm of load, repetition, large reach envelope, you got a problem. Now, these injuries can cost you quite a bit because it takes a long time to get these back on track. I actually have a large database with about 1,200 subjects in it, and we have about an 89% success rate for treatment with these. But I can tell you that they're going to start seeing changes in function at about the 6 to 8 week point. And so it takes a long time for this tendon to heal because it's got very poor blood flow. And so return to work is slow, particularly if you've got a large physical demand level. Very hard to get back to work. So in treatment, your therapist and your doctor has to be able to have a good diagnosis and have a good treatment approach to be able to fix this. And be able to control the risk factors and exposure risk factors in a graded manner. So you really want to watch these people and get them back on small reach envelopes with low load and low repetition, leave them a chance to get better. We put them in wrist gauntlets, put the wrist back in extension, about 4 degrees of extension. We stretch out the flexors here because they get really tight. and the flexors are 5 times stronger than the extensors. That's a 5-to-1 ratio of strength. And we strengthen the scapula with low trap, mid trap, rhomboid strengthening, and serratus strengthening. And that pulls the scapula back into retraction. It also gives us a bonus because when your scapula is in protraction, it actually creates an impingement of the rotator cuff and also impingement of the nerves. So there's a lot of different things going on, and scapular stabilization is a very, very bad animal when it comes to work injuries. And we found if we can fix the scapular stabilization and strengthen it, get it back into alignment, fix the posture, we can rest the extension mechanism, lengthen the flexor mechanism, and rest and activity modification. It goes a long way. These injuries can cause somewhere in that range between on how many systems are involved, between $60,000 and $80,000 per injury, but based upon what type of injury it is. If it's a ligament injury, it's going to take up to 5 to 6 months to get better because this ligament takes a long time to heal, and we have to treat it differently with a hinged elbow splint. Whereas if it's just tendon only, you're looking at 6 to 8 weeks. So it depends upon what type of injury it is. But that's why you always want to review the mechanism of injury, if it's a fall or a sudden jerk or whatever, to determine what's going on. Also realize the fact that when we talk about nerve injuries here to this elbow, we talk about the radial nerve, and the nerve gets trapped between the supinator and the extensor carpi radialis brevis, that when you do pronation supination with a lot of force, it's going to cause these muscles to swell. It's going to change the interval or the space for that nerve to lay in between those muscles. It's going to compress it. And the patients are going to complain primarily of their aching forearm. The forearm is going to ache down in their forearm here, not at the origin site. And so it's normally due to large reach envelopes again, but also pronation, supination, what we call torquing tasks that can create a lot of change the space. So when muscles work, they expand. And one of the flaw or design flaws of the forearm and the hand and the forearm in the body, human body, is that it has no place to go. The fluid has no place to go. The blood has no place to go. It expands and it crushes the softest tissue in the body, which is nerve. So therefore you have a nerve compression problem that occurs. And so, so if you can be aware of the fact, large reach envelopes with load, pronation supination, repetitive pronation supination can really get your nerve in trouble and really cause a lot of problems downstream for other pathologies that we've talked about in the past. And so that's very important to think about. I will stop and answer questions now before I go to the medial elbow. I've covered a lot of ground already. Anybody have any questions?
Yeah, we'll turn it over to our panelist, or actually one of our attendees. We got Sergio. Looks like he has a question. One sec.
Perfect.
Sergio, go ahead.
Can you hear me?
Yes, sir.
Yes, sir.
Thank you. I have a quick question on the tendon. You said there's not a lot of blood flow.
Right.
It might be is this the kind of situation where you would want to put, if you, as an acute injury and before you do anything, would you want to put something like heat on it to get more blood flow? Or is it still good to put ice on something like this? Or does it not matter?
No, that's a great question. And what we do is normally use ice, but we use ice cups. And so we'll use an ice cup because you want to put very focal ice on the tendon itself around the epicondyle. And you could over ice it because you really only need about 3 to 5 minutes of ice. So we use an ice cup. The reason we use ice packs is because the ice pack covers a large surface area and actually ices the nerve, which is bad. So you only want to ice the tendon, which is good. So 3 to 5 minutes of the person say, I feel a little burning, I feel a little aching here, but then once it becomes numb, you stop. And they can actually do this at home with a Dixie cup. They just ice it with a Dixie cup. It works real well. We use this post treatment. We'll ice this tendon down post treatment as a means to control the inflammatory phase, even from therapy. We're trying to get this blood flow and to this inflammatory phase to kind of calm down. We're trying to increase blood flow here slowly. We're trying to lengthen the muscles in the flexor compartment, rest these puppies, and increase blood flow with soft tissue massage, ultrasound, iontophoresis, all those things that are anti-inflammatory and increase blood flow is very, very important. But we really want to try to control the inflammatory process here. So the first 3 weeks or so, we'll use ice on
Okay.
the bone, if you will. Okay.
Wow. Thanks.
Does that help?
Yes. Thank you.
Any other questions about this?
Yeah, Greg, what do you early signs and symptoms? And I've had it. It was a miserable 6 months of my life to heal it. And I actually, but mine, it felt like it came on quick, or maybe I just ignored what I was doing. I think I was putting down landscaping mulch and with a shovel. But from a employer perspective or ergonomist, safety and health manager, what are going to be the signs and symptoms? What are going to be the early signs and symptoms?
They're definitely going to complain about pain right here, right the lateral elbow. Normally, if you can do some activity modification, increase the load, increase the reach envelope, maybe put a little off-the-shelf orthotic on the wrist. And the reason we put the orthotic on the wrist is because this muscle here controls wrist extension. So if you rest it, push it back into extension, it shuts down the EMG activity about 20%, 25%. So it rests the muscle. And then if you can stretch these muscles here, and all those are non-recordables, it's just stretching the muscle out, get a little off-the-shelf orthotic, something that's not going to be invasive, and rest them, ice the tendon. Then you got a good shot of shutting it down. And you obviously your age is going to play a big role too. So the better you are to identify it early, and then ice, just rest the tendon with the wrist or gauntlet and stretch, you're going to go a long way with trying to slow this puppy down. But I think what you said earlier, Steve, is that sometimes people don't realize it till it's too late. It gets the mule gets out of the barn, if you will, and it becomes a problem for people. And people are hard-headed. I'm hard-headed. I've had it in my left elbow for a while, and I know what to do with it, but I always continually flare it up because I'll go lift weights or whatever. So it's kind of hard to change your lifestyle. But this is it can become very irritated very fast. And you'll think you've got it whipped, and then you'll flare it back up. So it's kind of one of those things, kind of like a bad tooth. It can come back and haunt you. But the key is to identify what is the problem. And so you need to get in front of clinicians that know what's going on. But early symptom investigation is try to determine what happened with it, what caused it, and then try to say, let's stay away from that. Let's stay away from load, large reach envelopes, ice, and this gentle, and just rest it. And they should get better. They should see a change. Tendons see a change in about 2 to 3 weeks. So if you can put them on light duty for a couple of weeks, you should see a big change. If you don't, it may be something different.
And yeah, I hate if somebody else has got some questions, jump in. But my other next question is, what kind of activity or what kind of work motions are you seeing that are producing these? And the other thing, did you say $60,000 and $80,000 to treat it? And then
if it becomes a full-blown problem, yes, sir, $60,000 to $80,000 will be the cost, because they're going to be off for at least 12 to 16 weeks to get back to a physical demand level, medium and above, because it takes so long to get them back to conditioned. Because they're going to go through a deconditioning phase. They're going to decondition as they're trying to rest the tissue. So if you've got a combination, most of these come in combinations of tendon and nerve. They usually run, these are two of the most common problems, is tendon and nerve together. Very seldom you see a C-spine issue up top. And very seldom you see the radial head arthritis, but you'll see the tendon and the nerve combined. It takes a while to get these two calmed down. So it's going to be a time frame that's going to help you a lot. There are some good things you can use. There's what they call a quick dash that you can do. That's a questionnaire. And what we found with the quick dash, we've published this in several large articles, and that is the quick dash is a 11 question questionnaire. It gives you a score on 0 to 100. The smaller the score, the better. So what it basically means is that if you have a dash score, when you talk to your employee, you have a dash score that is above 60, greater than 60, that's a problem. That's a red flag. Okay. And then you do your dash score. We do our dash scores every week in therapy. And so our dash scores after the fourth visit should be less than 40. If it's 50, red flag. And then at 8 weeks, or I'm sorry, eight visits, which is usually 4 weeks, it should be somewhere around 30. If it's above 35 to 40, you've got a problem. So you're trying to you should see a trend or a change in dash scores going down. And that's perceived level of problem from the patient. And these are very, very accurate. We have a very large M with these. And so we can actually predict by week 8, I can predict if if they've got a 50 at week 8, they're going to fail therapy. They're going to fail. And you're going to have a very big problem. But the ones that are trending downward are going to have very good outcomes, and you don't have to worry about them. So if you're sitting at 8 weeks and you're sitting at 30 or less, you're going to have a great outcome. And this is a very large, very, very large and very, very predictable. And we use it all the time to predict functional outcomes. And then we spend all of our time on the ones that are at 50 or above at 6 to 8 weeks. If you're still above 50, we got a problem. And usually we pull in more people to look at it, or maybe we're missing something clinically, or there's psychosocial issues involved. They don't like their job. But we've seen this to be very, very strong predictor of a good outcome or a bad outcome is the quick dash. So it's just as powerful as it is as our clinical evaluations. And so we use that as a predictor. And then we use activity modification. We get them back into work slowly. So if I can get their pain level down, and get their motion normalized and get their strength back up to 60 to 70%, then we can start light duty activities. We send them back to work with 90% plus range of motion. This is a common rule for everything. And we also send them back to work with strength at 80%. And we actually focally test the extension mechanism with a little device that we can tone in on and test particularly those muscle groups. When they get 80% of the other opposite side, then we send them back to work with modified to regular duty.
Awesome. I think we have another question from Mr. Albert Moore. You want to?
Yes, sir.
Yes, Greg, I have a question. It was interesting the way you talked about the fluid buildup, that there's not much room for stuff to move around, so it ended up compressing the nerve. I was wondering, do we have data on what the duty cycle is, that if you breach that, you're going to have a more of a problem for the hand movements? And then also, what about the thresholds for like the MVICs or MG values that you have people lifting these loads? Like, what are we talking about here?
Well, what we know, this was actually research done back in the 80s, and it was done by Lind out of the textbook of work physiology. And basically what they looked at is they looked at the entire flexor extensor compartments. They looked at maximum voluntary effort, MVE, okay, MVE. And they looked at percentage of MVEs, they looked at blood flow. So if you work at 10% of your MVE, so let's say I've got a grip strength of 100 pounds, okay? If I work at 10 pounds, if I stay at 10 pounds or less with my work, my blood flow is going to stay around only a 10% occluded, only 10%. So I've got 90% blood flow available. And so my endurance factor is going to be, I'm going to have good endurance, and I'm going to have good strength throughout the entire work cycle. So that means I can do repetitive activity at 10% of my MVE. Now, if I go to 30% of my MVE, 30% of my MVE is going to give me a 50% occlusion of blood flow. 50% of my occlusion of blood flow is going to occur. And so the muscle is very needy of blood flow, but the nerve is even more needy of blood flow. So if you cut blood flow off to a nerve, it's going to shut down the efferent pathways to the muscle, and you're going to have a lot of endurance issues going on. And that's where you start seeing changes in endurance cycles and start seeing people fatigue quickly. And then if you hit 70% of maximum voluntary effort, in other words, 70 pounds, if I've got a 100-pound grip, you've got 100% blood flow occlusion, 100% blood flow. In other words, there's no blood flow going down into your hand, into the nerves in your hand, into the muscles in your hand, because the fascial planes have swollen so much at 70% that there's no blood flow into the hand. And so that's when while we set up jobs, we look at MVEs. And so we've got a mixed population of males and females. We take the female either average scores, or we actually test them online. And then we say, okay, what's 10% of that? And that's how we set up our thresholds for pinch and grip. If they're continuous, if they're frequent, we can go up into the 25-30% range. But if they're occasional, we can go into 70% range. But if they're constant, we got to stay at 10% or below of the weakest person on that line, or we're going to get an injury. We're going to have quality productions or quality problems, production problems, and injury is going to probably happen. And this is basic science this has been around for quite a while, and we use it as our indicator. The 10% is our indicator for what we're going to do for what we call constant work, and versus frequent work versus occasional work. And so that's kind of the breakdown. And I hope that wasn't too confusing, but I hope it helps. I don't know.
Yes, sir. That was great. I think we have one more from Steve.
Okay.
Yeah, and Greg, just from a body mechanics perspective, what do you see in this when you're talking about these things? Are you talking about elbow bent? Are you talking about reach? We're talking about, but give us something concrete that says, if I'm grabbing this part, or, what do you see? And I'm just curious as to those risk factors. We talked about them, but what does that look like operationalized?
Sure. So what I do is I draw a circle around the body, and I look at distance of reach. And so if I can stay in this circle of 14 inches or less inside, it's going to keep my elbow bent at about somewhere between 60, depending on how long my arm is, somewhere around 60 degrees or less. And so if I can do that, and I can keep a short reach envelope, it's going to be very important, because it keeps my trunk from destabilizing. It keeps my elbow bent at about 60 to 70 degrees, and it stops scapular destabilization. Once I go outside this circle, like at 18 to 20 inches, I start having visual problems. I start having visual acuity problems. I've got a large reach envelope now. My arm is fully extended, and the palm is down. The palm is down towards the ground. So I got a large reach envelope. I've got a large reach envelope with my palm down. It puts excessive stress on the elbow, particularly the muscle trying to co-contract to keep my elbow extended and stabilized. So the muscle's trying to co-contract. The ligament is at full tension, and it gets in trouble. The bicep can't help it a whole lot, and the tricep can't, because at end range, those muscles are very weak at end range, versus the muscle at mid range. Here in this zone here, the muscle's still working in mid range. You've got a lot of muscles available to help protect the joint, protect the muscles. When it goes to end range, you really hang on the ligaments, and it puts a lot of stress on neural tension on the nerve. It destabilizes the scapula, destabilizes the trunk. So anything above 14 inches, you start getting in trouble. 20 inches, you really start getting in trouble, because it really impacts your visual acuity as well. So palm down, large reach envelope, then you add frequency and load on top of that posture, and you're in trouble. So you got posture, frequency, and load. You get in trouble very quick. Remember, every pound of pressure you put here in the hand, let's say I pick up a gallon of milk, it weighs 8 pounds. Well, 8 times 30, let's say my arms are 37, let's say 8 times 35, you're getting into 200 pounds of force at the shoulder, and you're getting about somewhere around 90 pounds of force at the elbow. It becomes a big deal. So weight is a big deal. So we usually try to keep the loads at 14. We keep the loads somewhere between 2 to 5 pounds. But as we get out to 18 and 20, we keep them way down, somewhere around less than 1 pound, way out. We try to. That's ideal world, but that's really getting a lot of forces when you look at that. I don't know if that helped or not, but that's kind of how I look at it.
Yes, sir. Thank you.
Any more for the lateral elbow? All right. Well, we will dive into the medial elbow now. And I'm going to take away some muscles, strip away some muscles, and talk about the medial elbow. The medial elbow is very distinct. You can see how it kind of protrudes outward here. And the reason why it does is because it actually has quite a bit of large muscles that insert on it. So you have your large wrist flexors insert on it. You have your very large digital flexors insert on it. And then you have your smaller wrist flexors insert on it. So it's a very big, strong muscle. And it's very big ridge of bone that receives or has an origin for a very large, big muscle groups. And so the first thing I want to talk about is basically the joint itself. And this joint is interesting. It's very cool the way it's designed, and the fact that its ligament is very cool. It has two major ligaments. One of the ligaments is called the posterior capsule, and its orientation, its fibers are orientated this way. Well, let me see. I'm sorry. It's orientated this way into the elbow, and the other one, the anterior bundle, is orientated this way. And so this ligament stabilizes the elbow in both flexion and extension. And so one of the first major problems that we see with this elbow injury is these ligaments can get in trouble, particularly if you have somebody that's swinging a hammer all day long and they have a lot of laxity in this ligamentous system, and they go out to full end range and they have a jolt or a sudden stop. It really puts a lot of stress on the origin of this ligament. It also puts a lot of stress, believe it or not, on the radial head. And so the radial head itself here can get in trouble. It can really get in big trouble because it's a doorstop. When this ligament is taut and you have impact, the doorstop basically is the radial head against the capitellum. So it really can cause a lot of really soreness in the elbow itself, which is a big deal. And so we can see a lot of medial elbow injuries here, ligamentous injuries, from a lot of high force activities. Again, goes back to people that put floors in, people that do a lot of heavy hammering with large reach envelopes, a lot of jackhammers, a lot of sledgehammers. You can really get in trouble with this ligament. So the stability portion is very important. Now, the next thing is it's very important to understand we have a very common nerve injury here. It's called cubital tunnel. And so we put the nerves in, and this nerve that goes around the elbow can get really sick, extremely sick. And this nerve is the power nerve of the hand. The radial nerve we talked about before is the functional positioning nerve. So it brings your wrist into extension, opens up your digits. The ulnar nerve gives you power, it gives you grip strength and lateral pinch strength. And so when you bend your elbow up into flexion, it pulls this nerve around the medial epicondyle like a garden hose goes around the corner of a house. And it actually tractions that nerve and actually cuts blood flow off that nerve. And so it's a really big deal. So the floor that the nerve cruises on is bone. And then the ceiling for the bone, for the nerve is muscle. And it's the biggest, most powerful muscle in our form. I call him Superman. He's called flexor carpi ulnaris. He never gets sick. Very seldom you see FCU get sick, flexor carpi ulnaris. It's the muscle that drives nails. When you drive a nail with a hammer, that's the muscle you're using to drive the nail. So it makes up the roof over the cubital tunnel. And so when this nerve gets sick, normally with the elbow flexion, and particularly when we sleep at night, the nerve can't rest, so it gets irritated from this posture. So it's postural driven. The elbow inflection creates the tension on the nerve, and it's a big problem. So what causes this problem to occur? Well, repetitive elbow flexion extension. When you're feeding like you're feeding a machine back and forth with parts, boom, 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 elbow flexion extension, you're tethering or moving that nerve back and forth, flossing it back and forth but underneath the bone and in between that muscle and tendon, and it causes irritation. When that irritation occurs, the nerve becomes inflamed and it can become compressed. And then downstream, what happens downstream is the muscles in the hand itself can become weak and atrophied, and all the intrinsic muscles can become weak, and the thumb muscle can become weak, and you lose grip strength and pinch strength. The grip strength primarily comes from the big muscle here, the flexor carpi. I'm sorry, the flexor digitorum profundus, which is also innervated by the ulnar nerve. So everything distal to the elbow can become sick. So you lose grip strength and pinch strength, particularly lateral pinch strength. And so this is a big entity, a big problem. We see a lot of this in all types of industry. It can be a jeweler where they sit there for hours with their elbows flexed. It can be a truck driver that puts their elbow on the door and lets it rest for hours at a time and puts compression on here on the nerve. And so the risk factors are pretty straightforward. You got repetitive elbow flexion extension. You got mechanical stress. You've got the awkward posture of just elbow flexion itself for long periods of time. You've got large reach envelopes with force that's going to cause some stress here with the muscles. And so you really got that big problem. But I think probably the key point is repetitive elbow flexion extension and then continuous elbow flexion posture. And like I said earlier, the sleep posture is extremely important because how do we treat this? We put them in an orthotic that actually blocks their elbow flexion. It keeps them from flexing. So it actually allows the nerve to rest. And so it allows the nerve to calm down because when we sleep at night, we sleep in a fetal posture. Our elbows come into flexion, our wrists go into flexion, and we sleep with our hands clenched like that. And so the nerve can become compressed over a long period of time. So we can control the exposure of that posture at sleep at night. And then we also control, again, the reach envelopes. The reach envelopes we control and try to keep them to where we're not reaching back and forth with repetitive motion over and over and over again, back and forth, reaching back and forth, causing that elbow to flex, extend, flex, extend. And then if you have a work where you have to have a lot of ulnar deviation with force, that causes the flexor carpi ulnaris to fire and compress here and pile in here and put pressure on the nerve when you're doing the activity. Another reason why the ulnar deviation and radial deviation is very, very stressful on the nervous system and the muscle system of the arm. And then this is a very common problem. We often see surgery for this. Therapy will work as long as the nerve is not subluxing. If the nerve is, so when I test the patient in the clinic, I'll pull their elbow up here into flexion, and I will actually put my fingers underneath the cubital tunnel and hold them there. And if the nerve pops out, in other words, you can feel it pop, the patient say, I feel a snap, and it pops out, that patient's probably going to have surgery. And you're looking at, by the time you go through rehab, surgery, rehab again, work conditioning, work hardening, you're looking at this patient being out of commission and going back to work for somewhere between 16 and 20 weeks. And you're looking at a cost somewhere between $70,000 and $80,000 by the time you pay for surgery and everything else. And so early recognition is extremely important. They're going to complain of numbness and tingling in the ring and small finger. That's what they're going to complain of first. And they're going to complain of occasional numbness and tingling. But as it progresses, it's going to be constant, and that's a problem. Or if they have subluxation, that's a problem. Because you're not going to, you can say, I'm going to put you on light duty forever. But if they're subluxing here, it doesn't matter. The mule's out of the barn. It's less than 5% that have this, but when they have it, they're going to have surgery. And surgery sounds scary, but actually they've gotten very good at this surgery. They do what they call ulnar nerve transpositions, and actually just move the nerve from being underneath the epicondyle to being above the epicondyle. And so when that happens, when you bend your elbow, it actually puts slack in the nerve. And so they did away with the biological problem, if you will. And so the recovery on that is about 10, 12 weeks post-surgery. They go back to most activities and they do very well. Light duty activities, they can go back to work as early as 4 weeks. But heavier activities, lifting, push, pull, repetitive motion, it's going to be about 12 weeks or so. But again, it's a problem that is prevalent, but can be fixed and identified early. We have very good results. I can tell you that at the place where I worked at for 18 years on site, for a long time, we would do over 200 long arm splints a year. And we got to where we only were doing less than 15 because we would incorporate scapular stabilization with the treatment of ulnar nerve problems. And it worked out real well because we found that people had a lot of destabilization, put a lot of stress on the nerve, with activities and with ADL activities like things they do at home. So it's very important to think about the entire kinetic chain as you're seeing these problems, and fix the entire kinetic chain from the shoulder all the way down, not just the elbow itself. And I think that happens a lot in rehab and a lot in medicine itself. We become too tunnel visioned, if you will. The other big problem here is called medial epicondylitis, and this is not a big problem for me. And I'll tell you why. Because this, unlike your lateral epicondyle, this muscle group here has a lot of blood flow. And so this animal heals very fast. We put them into a wrist gauntlet at about 20 degrees of flexion, and we rest the tissue, and we actually start motion right away. And we actually start loading this muscle at about 2 to 3 weeks, and we get great results with this. So if we don't have a nerve issue or a nerve issue, and we only have medial epicondyle issue, orthotic, gentle therapy, load it at 3 to 4 weeks once we have full motion, these go back to work very fast, usually in about 6 weeks. And the cost is very minimal. But if you catch them early and treat them early, the problem is small. If you wait a long period of time and you have a tendon problem and a nerve problem, you got a big deal. Now, if you got a tendon problem, or if you miss it and you don't have a tendon problem, but you have a ligament problem and you missed it because they didn't do the appropriate diagnostics on it, and you can easily do passive range of motion and test the ligament and not the muscle and identify the tissue. So good diagnostics up front with all these problems play a big role in identifying the appropriate thing to treat to get them back to work safely and efficiently. And oftentimes, I'm telling you, people, the average therapist looking at this has a hard time with diagnostics. And I think that's one of the biggest things that we have to look at with, and we do a lot of education with med doctors, general practitioners, general orthopedic surgeons on how to diagnose these things and be very proficient at it. So we can, you can't shoot what you can't hit what you can't shoot what you can't see. And so you're very, very important to identify the problem and treat it. And I think that's really what was important message here. The medial epicondyle, they get in trouble, so this is often called golfer's elbow. And so a lot of repetitive motion with wrist ulnar deviated and wrist flexion with weight and a large reach envelope will get you in trouble here. And so again, rest, lengthening the muscle, scapular stabilization, but we can be much faster. It's almost 3 times faster than a lateral elbow problem as far as healing goes, and very good outcomes. So there's the tale of 2 cities: blood flow, no blood flow; quick recovery, not quick recovery. Five different reasons why, only a couple reasons why. So there's a big difference in the dichotomy of what's going on with these different types of problems. So questions, I'm open for questions.
We will to the panelists. Anybody want to chime in?
Is there a particular reason why you call the muscles animals, Greg?
Nah, just habit.
Okay, I just didn't know if it was like I just didn't know if that was technical or something.
Sorry, I'm using slang. I'm trying just to make it
Hey,
fun.
I can dig it. If it's your slang, it's my slang.
I can become really scientific, but I've been beat up for that. So I'm trying to make it a little more relaxed.
And it looks like we have a question from Miss Ann Hall.
Yes, Dr. Hall.
Not a doctor, but anyway, Greg, I was thinking when you're seeing patients come in for some of these issues, do they tend to keep coming back if they're going back to the same job, even if they've had the rest period? How susceptible are they to re-injury?
I think depends upon the age, Ann. And obviously we all face people that are fragile workers that have been put in the wrong job, just from physiological point of view. But a lot of them do well if we get their systems in a good homeostasis, so they're balanced out. We don't do a lot of strengthening with these. One of the things we really strengthen is the scapula. We do a lot of muscle balancing, tendon glide, nerve glide, try to get the system to calm down. And if we can get their scapula and if we get the muscles normalized in length, and stop the pain reflex. And then if we can get the scapula strong, the trunk strong, and the hip strong, then you really have a good chance of getting them back to work. What happens though, Ann, is people, they don't do scapular stabilization with patients. They don't do trunk strengthening. They don't do hip strengthening. And they end up going back to the work, and they don't treat the root problem, which is going to be the core stability. And you see it with professional athletes, people that are like the pitchers. I have pitchers all the time come in, college pitchers that can throw 95-mile fastballs. I have them stand up and say, do a one-legged squat for me. They fall on the floor because they've not done anything to strengthen their hip and their core. Then you check their scapula out, and their scapula is all over the place. It's very, very bad scapular dyskinesia. And so nobody's working on really what keeps you safe or keeps you healthy is core stability. It keeps the injury away. Does that make sense?
Oh,
And
yes. So you're saying it's kind of a holistic issue too. Like you have to look at the whole chain and the whole body.
Definitely. And so few providers do that. It's not common to look at the entire kinetic chain. And so therapy, they'll do ice on the elbow, and they'll do some range of motion on the elbow. They'll do nothing for the scapula, nothing for the trunk. And so therefore, when the patient goes back to work, guess what? They fail because they don't have the entire system fixed. They only took care of the pain, not the root cause.
Thank you.
Yes, ma'am.
You can go ahead, Steve.
Yeah, one of the things, of course, most of my time now spent on construction sites, but I see these pop up from hammering, typically hammering overhead, and same with jackhammers. And one of the things that you see very rarely, unless you have an educated group, is in the like the anti-fatigue gloves, the gel gloves. There's the transmission of vibration. What role does that play in that, Greg?
I think the vibration, particularly with sledgehammers and jackhammers, can be very, very bad, particularly on two systems. One is the general peripheral nervous system, but two is the Golgi tendon organ, and the GTO controls force regulation. And so vibration is a very big enemy to the GTO. And so what it does, basically, it shuts down its ability to regulate force. And so that nerve ending sets in the tendon and allows the body to regulate force. And a good example is that everybody's ran a weed eater, like a gas weed eater. You look down at your hands after 20 minutes of that, and they're just like snow white because you're gripping it so hard. And what's happened is the vibration is shut down the GTO, and now you're squeezing because you don't have force regulation. You've lost that ability to have force regulation. And so then you work harder, which puts more stress on the tendons and the nerves and put more mechanical stress through the hand. It's a vicious cycle that occurs. Now with hammering, overhead hammering like a sledgehammer stuff, that is a grueling work. That's a young person's work. And so, if you've got somebody that's 40 or 50 years old, which we have a lot of people doing that now in their 40s and 50s, they're going to have some trouble with that down the road. They're going to have some shoulder impingement. They're going to have some nerve compression going on because they're probably destabilizing their scapula, but more importantly, it's just heavy work. We use a product called PPT from 3M, and it's a pretty cool material. It's only about a quarter inch, maybe not even a quarter inch, less than a quarter inch thick. And I can take and wrap my finger with it, hit a hammer with it, I won't feel it. And it's very pliable. And we line gloves with it all the time, or we'll actually take and line tools with it. We can cut strips of it and line tools with it. It's great for deadening vibration and also for controlling mechanical stress. So we found success with those. And oftentimes we'll send people to like Walmart or Kmart and buy a set of weightlifting gloves and then put the PPT in it. I've not been happy or successful long-term use of these high impact gloves for like tool use, for repetitive tool use, because it changes the knack. The Japanese call it the knack, the ability to be able to control that tool with a lot of precision. And so they lose that sensory feedback loop. So most of the jobs that I see that are repetitive in nature that have vibration, they've actually engineered the vibration out through tool design not through human adaptation. So construction work, I think it's great for it because you can put them on, take them off. But for like building a car or doing something like that, I think it's a higher level in engineering, macro engineering effect. And the PPT, I've been extremely happy with that stuff. I mean, it's very durable, and you can apply electrician's tape over top of it, make it last a long time. It's pretty cool stuff. That's just one example. There's several different things out there that will do similar stuff.
Yes, sir. Let me go ahead and share my screen.
Let me get out of this. I'm sorry.
No, you're fine. I can do it from here.
Stop mirroring. Back.
Sweet. Yeah, we'll see if any of the panelists have any more questions. Mr. Moore, Melissa, Nicole.
I'd like to know what program you're using for the anatomy.
This is called Essential Anatomy 5. It's the little brother to Complete Anatomy. And I've been using it for a long time. I like it a lot. I can layer in and out very fast, and I can superimpose, as you've seen, different types of pathologies discussed with it. I like it a lot. There's another app I use a lot. It's called Explain Everything. But those two apps I use almost exclusively, particularly on a platform like Zoom. But they work really well for educational purposes. They're not expensive. That little anatomy app's like $25 is all it is.
Okay, great. Thank you.
You're welcome. You also can tape with it, and you also can take pictures with it and make PowerPoints out of it.
Sweet. Well, thank you, Dr. Greg Pitts. I'm going to give it over to Steve. He's going to give us a few words, but again, it was an awesome presentation. Thank you to all the panelists for asking questions and the attendees for asking questions as well. We appreciate it all. And Steve.
Yeah, thank you, Ray. First of all, I wanted to thank Ann, Melissa, Albert, Nicole. I appreciate you. We appreciate everybody, participating in this, and we're getting a lot of good feedback, good questions, and the more information we can get out. But you gave up your time, and you all are all experts in what you do, and on behalf of the Ergonauts, I want to say thank you very much. Same thing with you, Greg. You are an Ergonaut, but you've got a following now of people that are following your training through Mission Control. Same thing with you, Ray. Thank you so much. And the other thing we wanted to talk about, this touch on the sponsors. You got Superfeet. We're going to be our next Mission Control is going to be in September. And we're going to be doing lower extremities, and we have CPAD from Superfeet that's going to be putting that on with us. So that's one of my favorite products. We have no financial relationship with Superfeet. We don't make it. If you buy their product, that's great. You'll be happy you did. We don't get paid for it. If you don't buy it, we don't get paid for it either. So same with LilyPad. They've designed a brilliant product for home offices, and it comes in and you set it up, and you can be working on it in half an hour. Commonwealth Hand Therapy, that's Greg's clinics. He's got a chain of clinics in Central Kentucky. Ergo Office, that's our office product that we have. That's our training program and our app. We actually have a big announcement within the next 30 days. With regard to the Ergo Office. Atomic Ergo, it's a fun podcast that we do. Our host is Rey Lira, and he does an amazing job. We've had fantastic guests on there, so very happy with that. Same with Mousetrapper. We love their product. It's something that we hope we see it take off more in the US. And then there's excuse me, Ohm seating. I'm sitting in an Ohm seat right now, so it's a 3-piece assembly, no tools required, and it's very ergonomic. We did an evaluation on it, and that's one of our favorite products as well. So anyway, and then there's iHealth 360, and we have a friend, Lanisha, and she has founded a a company that they're getting ready to do some cool stuff, and they're doing their launch, and we consider her a an ally. So I wanted to mention that, but that's all I have. These are people that we care for, and we love their products, and so that's all I have, Ray. Thank you all.
Yeah, awesome. Well, once again, thanks everyone for joining us today. Thank you, Dr. Greg Pitts. We appreciate you. And we'll be posting this soon. So if anybody wants to review it again and show it to their friends or family or in a classroom setting, I'm sure they would appreciate it. And
if I can help anybody, please let me know. My phone number is 859-509-5383. Did anything at all, please let me know. I hope any way I can.
Thank you,
thank
Greg.
you, sir. Everyone have a good night.